Hi, this is the preview of the lecture video on sonography of fetal hydronephrosis. The various snippets of the topics covered under this lecture video will follow. Having gone through the preview, if you wish to listen to the main lecture video, go to sonoshare.in. Once you reach the website, this is the home page. You scroll down the home page and you will get the icons of various lectures available, and click on whichever lecture you want to subscribe. You would have seen the preview. You want to subscribe for the lecture, so click on the icon. And if you have any doubts, you can also see the ShonoShare guide, which is available in the home page in case of any difficulty. On the fetal thorax, then you will go to preview page of the lecture video you have selected. So you click on the red bar and it will go to the page of the particular lecture video, the amount and the duration you can watch. And you click on the buy and it will go to the payment page, make the payment, and you will receive a confirmation email. Once you get the confirmation email, you log and view the lecture video. Thank you.
Is ultrasound of fetal hydronephrosis and associated anomalies. Now again we have to start from the guidelines, better seen from the posterior aspect by an axial scan. You see the kidneys as we see the this is at 30 weeks in the third trimester. You see the axial scan again appears same, but when you use the high frequency linear probe to see the architecture or the pattern of the coursing around the bladder. So that is the technique of looking at uniformity on how to define the dilatation, classify the dilatation, grade the dilatation, attempt by this multidisciplinary consensus on the classification of vesicoureteric reflex, more common 10 to 40%, and it may be very rare causes like ectopic ureteric opening, duplex collecting system, urethral atresia, etc. to approach the fetus. So it is the diagnosis extends postnatally, and it is done by imaging, ultrasound, urinary. Looking for urinary tract dilatation. The measurement you take is the anteroposterior renal pelvic diameter. Additional ultrasound features like calyceal dilatation, which is seen on a coronal scan. The parenchymal thickness, it is done by up to 4 millimeter before 28 weeks and up to 7 millimeters before 28 weeks. After 28 weeks is taken as normal. The urinary tract dilatation in the fetus is divided into two groups. A low risk group of UTD-A1, where the postnatal risk is low, and an increased risk group of UTD-A2. And so it is 4.7 and 4.5. So it is less than 7. So it is UTD-A1. In the third trimester, it is more than 7 to 10 mm. So it is a echogenicity. So when you see any one of these, even when the measurement is less, you call it UTD-A23. Now, what is the use of this classification? It is useful in the follow-up management of. So you have to be careful. So to do the postnatal scan little later, preferably after a week or is possible, you aim for a more definite diagnosis by doing an extended fetal urosonogram, like fetal echocardiogram. You can do an extended fetal urosonogram 10 millimeters in third trimester with a calyceal dilatation. So when you see like this, then what is the protocol? So what is the protocol of extended fetal urosonogram? First is a coronal scan of the kidney, dilated collecting system. But when you do a coronal scan, you see that the calyces in the periphery are communicating with the dilated renal pelvis. So that means cystic area in the upper pool. And because it is a coronal scan, you see that the dilated This is actually dilated upper moiety, which is continuing as the dilated ureter here. So this differentiate, but here there is no. Then you look for the dilated ureter. So when you do the coronal scan of the kidney, you see the dilated upper ureter. Then you can trace to look for the dilated mid and lower ureter. Diagnose ectopic ureteric opening into the vagina or urethra. So this is the use of fetal perineal ultrasound, and this is in the male fetus, again from posterior to anterior. You see the rectum. When the fetus maturates, you see actually slight dilatation of the urethra. This is the bladder, posterior urethra, and then the anterior urethra in the shaft of the penis. And you look for the kidneys, then you fail to see the renal arteries, and you have a suspicion of a lying down adrenal sign. But same fetus, if you do endovaginal scan, you see how much clear it is. You see the nice renal arteries. You see a nice bladder with umbilical arteries, pelvic-ureteric junction obstruction. Whenever you see PUJ obstruction, you have to mention the AP diameter of the pelvis. Pressure is taken away by the pelvis, so the parenchyma is spared. So the presence of an intrarenal pelvis is a bad prognostic sign. So again, looking at the parenchyma in case of PUJ obstruction or any other obstruction, you see the appearance, the parenchyma appears echogenic with size. So PUJ obstruction with dysplasia may evolve into multicystic dysplasia. Or as seen here, now this is a case of dysplastic that there is parenchyma around the cyst, which confirms that there is hydronephrosis of the ectopic presacral kidney due to a PUJ obstruction. So this is on the same side with in continuity with the hydronephrotic kidney. So it is crossed renal ectopic kidney with a PUJ obstruction of the one of the kidneys. So here the renal pelvis is almost normal, only the calyces are dilated. That is megacalicosis. It is a ureter ending in a ureterocele. So ureterocele with a almost total obstruction resulting in obstructive dysplasia of the kidney and obstructive megaureter. You may see hyperperistalsis also. Now this is when you look for the collecting system, you see over time, here you see the dilatation and the dilatation here. So varying dilatation of the collecting system, and the ureter is also dilated up to the bladder. So this is again another feature of vesicle, narrows down and it opens into the urethra. So this is ectopic perineal, ectopic opening into the vagina, causing hydronephrosis. For gross hydronephrosis, one condition we saw is the multicystic dysplasia and how coronal scan differentiates. So this is typical appearance of a lymphangioma, lymphangiomatous cyst, which does not respect the boundaries, so extending from the retroperitoneum to the glute, resolving adrenal hemorrhage. The renal pelvis, upper ureter, and huge dilated upper ureter. So this is the schematic representation of the pathology. So this is the appearance you see in a ureteric valve. There is hydronephrosis of the more commonly involving the upper moiety, and when there is double collecting system, the upper ureter usually opens lower and medial, but you see the ureter which extends down into the pelvis and opens into the vagina. So this is ectopic ureteric opening into the vagina. Then we come to bilateral hydronephrosis. So whenever bilateral hydronephrosis is seen, we have to look for the amniotic fluid. And a coronal scan, you see the dilated calyces communicating with the larger renal pelvis and ureter is seen. So that will be absent when it is when there is urinary bladder outflow obstruction. And this is a coronal scan, and you see the keyhole appearance, typical keyhole appearance due to the posterior urethral valves, so urinoma and ascites. Now, posterior urethral valves has a big spectrum, varied. Here it is dilatation extends into the shaft of the penis, so that is the anterior urethra which is dilated, and so here you see the dilated anterior urethra. This is the posterior urethra anterior. This is vertical. This is horizontal. Extends into the shaft of the penis. This is the penis, and that is the glans penis. So it extends into the shaft of the penis. So this is typical appearance of anterior urethral valves. These are also dilated. When you come to the bladder, it is massively dilated, protruding out of the abdomen, and you see the bladder. So this is normal penis, and you don't see the dilated urethra. It looks solid, whereas here it looks hollow due to the dilated urethra. So this is a condition called anterior. Then it results in an anterior urethral atresia. So you rule out that by putting on color Doppler, showing that there is no flow. So this is the typical appearance of megalourethra. So here the megalourethra you get, so that shows that it is lacking muscles both in the bladder wall as well as the anterior abdominal wall. So that is a prune belly syndrome. So this you can see the bulge outside and thin abdominal wall. You can appreciate it's not good by the abdominal roof. So I have done an EVS. So endovaginal scan, which brings out the details better. So here you see the dilated tortuous lower ureter extending low down, and that is the ectopic ureteric opening into the vagina. So this is bilateral ectopic during micturition. So that is why we do micturating cystourethrogram to confirm posturethral valves. So similar micturating cystourethrogram you observe in the fetus in the form of the perineal scan looking for the micturition. So when the fetus maturates, you see the bladder is emptying, and you see the huge dilatation of the posterior of the penis up to the mid shaft. So that is the difference between the two conditions, and you can see the video, that is the dilatation of the posterior urethra, and during maturation you see the dilatation extends, but the urethra is normal. So this is a condition called megaureter megacystis association. This is due to bilateral vesico-ureteric reflex of dysplasia. Gestation age at diagnosis, as seen in posterior valves, manifest in the first trimester sequence. So what are the types? There may not be any perineal opening when you see that is most severe form. There is no external opening. The first most important thing is non-visualized anus. You may see a cystic mass, either separate a specimen showing no anus. So this is a partial URSM sequence with a single opening. Mass in the lower abdomen and perineum. So that is the mass, irregular mass, indicating extrophy of the bladder, and the anus may be non-visualized, which may do an extended fetal urosonography, arrive at a specific diagnosis as I have shown in detail, and look for associated anomalies which affects the